Dr. Midun is not joined. I'll just call him.
Yeah, please do.
ISMBO IMO Ampok PG case discussion. Today we have Dr. Abul Hussain. He is the final year DRNB Medical Oncology resident at KIMS Hospital, Trivandrum. Along with that, we have two eminent examiners. Dr. Wesley Josa is the professor at Amrita Hospital, Kochi, and Dr. Mithun is from Jubilee Hospital, Thrissur. Over to you, examiners. You can start the session, sir.
All right, Abul.
Yes.
Good evening, sir.
The eminence part of it you can leave aside. Munir has just been making it sound very big. Okay. Me and Mithun, both of us are just your seniors. We have also come the same way that you have come. Probably you're following us a little few years later. Okay. The idea of the exam is not to test how much you know. The idea is to test how well you are able to approach a case. You understand what I'm saying?
Okay,
So
sir.
don't panic if you're not able to answer all the questions. It is not mandatory to answer all the questions. Okay?
Okay, sir.
But carefully about what Mithun asked you or what I asked you. And before you jump to an answer, think and then answer. These are all practical questions, and how you approach is what we are trying to figure out. All right?
Okay, sir. Okay, sir.
All right. You can proceed.
Okay, sir. Thanks. Good evening, all respected faculties and dear colleagues. I'm Dr. Abdul Hussain, second year medical oncology at KIMS Health Trivandrum. Today, I'm going to present a case of a 61-year-old lady hailing from Kollam. She presented with abdominal distension and discomfort of 2 weeks duration. History of present illness. She was apparently asymptomatic 2 weeks back when she developed abdominal distension and discomfort, which was diffuse. Incidence in onset and dull aching type, intermittent, not radiating. And there's also associated early satiety and decreased food intake. There is no nausea or vomiting, no other aggravating or relieving factors. There's no loss of weight or loss of appetite, edema, bleeding PR, no hematemesis, no bleeding per vagina, vaginal discharge or mass per vagina, or no fever, no yellowish discoloration of eyes or skin, no cough, chest pain, hemoptysis or breathlessness, no back pain or other body pain, no groin swelling or pedal edema, or no lump or pain in the breast. Past history, she has a history of diabetes mellitus, hypertension, dyslipidemia of 3 years on treatment. There is no other medical illness in the past. There is no history of surgery in the past, except for LSCS. Menstrual and obstetric history. She attained menarche at 14 years of age. Cycles were regular. 28-day cycles last for 5 days. Married at 22 years of age. Para 2, live 2, with both children LSCS. Childbirth first at 24 years of age and second at 28 years of age. Breastfed till 2 years of age. There's no history of any infertility treatment, no history of any OCPUs, tubal sterilization, or other contraceptive history, no history of hormone treatments. She attained menopause at 50 years of age. Personal history, she's a mixed diet, sleep, bowel, bladder habits normal, no history of any drug allergy, no history of any smoking or alcohol use, no history of malignancy in the family. There is no previous treatment histories. To summarize, this is a 61-year-old para 2 live 2 postmenopausal lady with history of diabetes, hypertension, dyslipidemia, presenting with the complaints of abdominal distension and abdominal discomfort of 2 weeks duration.
Okay, Abdul.
Go ahead, listen, go ahead.
Yeah, no problem, sir. Continue.
Abul, based on your history, the only two positive findings that you had or positive history that you're mentioning is abdominal distension and discomfort. You did not go into details of the discomfort. I'm not sure what you actually mean by discomfort. It's always best to be clear about it. Discomfort could mean pain, discomfort could mean mean inability to eat, it could mean early satiety, it could mean multiple things. So be a little more clear about discomfort. Abdominal distension, was it specific or was it a diffuse abdominal distension? And do you make any difference based on the abdominal distension? We're just trying to slice what abdominal distension is that you're meaning.
Sir, the abdominal distension, she's having a diffuse abdominal distension.
Okay, let's say if it was a lower abdominal distension or let's say it's a upper abdominal distension, would that make any big difference?
Yes, sir. The possibilities of the lower abdominal distension, especially in a postmenopausal lady, the chances in terms of the differential, what we think about will be different. We'll be probably more thinking in terms of a gynecological related condition. And in an upper abdominal distension, we would be more probably thinking regarding of a gastric or an esophageal problems.
Very convincing. Gastric, yes. Specific in gastric?
Hello, sir.
What more specific in gastric would you think of? Gastric is again a big diagnosis. Gastric, how many patients have you seen coming to you with an upper abdominal distension? Rarely they come like. Are you able to hear me?
Yes, sir. Yes, sir.
So upper abdominal distension is not a very common finding of a stomach malignancy, but it is there. In which condition? Probably if there is a gastric outlet obstruction. That is when you have somebody who comes in with distension, upper abdominal distension. What else could have been there? Upper abdominal distension, somebody with same sort of symptoms, some abdominal discomfort and distension, 2-3 weeks.
Hello, sir. I'm not able to hear. Sir,
you be able to think of something else other than stomach in the upper abdominal distension?
Other than the malignancy, sir. Malignancy part.
The malignancy. We're not talking about anything other than.
In the malignancy. Okay, sir. Sir, it could be a carcinoma causing an obstruction, or it could also be a lymphomas with a nodal obstructions, nodal disease.
It can be large nodal mass. It could be probably lymphoma, sarcoma, any of those. Could this be a large spleen?
Yes, sir. Splenomegaly can.
Yeah, a large spleen, a patient with ML, patient with splenic marginal zone lymphoma, patient with hairy cell leukemia might present with something in the upper abdomen, very, very similar symptoms. So don't assume that because it's a 60-year-old lady and has got an abdominal distension with discomfort, it always has to be ovarian malignancy. That is not how we assume. When you go in for exam, remember the diagnosis is not expected. What you are going to tell, because we are told that it is ovarian malignancy, we already know that you're going to talk about ovarian malignancy. So the idea is to consider all the other possibilities, right? So in your history, when you went around telling all the negative histories, it was all about just checking the boxes. Instead, it should make sense. When you say abdominal distension, rule out the primary causes of abdominal distension of each quadrant. Or if you're saying a diffuse abdominal distension, then do talk about all the other options that you have in terms of diagnosis. That is how you reach the differential diagnosis at the end of history taking. Okay? So that's just something that you have to. Nathan, do you want to add something?
Nothing as such. What do you think with such a diffuse abdominal distension and discomfort, what will be a differential diagnosis in such a scenario?
Sir, one is most probably it can be a ovarian, especially she's a postmenopausal lady, and there can be a ovarian malignancy with maybe associated peritoneal disease, or it can also be a intestinal malignancy with also with peritoneal disease, or it can also be some GA malignancy with the associated Krukenberg tumors. Then that will be the first primary differential, sir. Then it can also be
Okay.
that will be the more probable differentials, sir.
Okay. Any other means we should always think, being a medical oncology examination, you should always think of oncology. But any other non-malignant causes that can also cause such diffuse abdominal distension, that should also be kept in our mind. Because this
Yes, sir.
patient in serious onset, you're telling about 2 to 3 weeks. Any other differential diagnosis that can
It can
come
be
to
a
our mind?
non-malignant effusion, like a Meek syndrome. It causing a distension, or it it can be tuberculosis.
Yeah. In India, we should always think of
Tuberculosis.
tubercular causes. Yeah. Okay.
Tuberculosis.
Okay. I think that's it. We can. Yeah.
Okay. So in your differential diagnosis, what are you considering? What is your differential diagnosis at the end of this particular history presentation?
Sir, first differential diagnosis will definitely be thinking the short duration of the presentation, as well as being considering the age of the patient. The first differential definitely will be carcinoma of the ovary. And the second differentials will be a colonic disease with the colonic malignancy. Then the third differential can be the gastric malignancy with a Meek syndrome, with Krukenberg's. Sorry, sir, with the Krukenberg's causing the symptoms, or it can also be an other, like a lymphomas. That's a rare. The other will be
one is ovarian malignancy. Second
yes,
one
sir.
you said is a colonic malignancy, and the
Yes,
third
sir.
one you said is Krukenberg.
Yes, sir.
In your clinical history, what are the points in favor or against each one of these?
Sir, in the history, the one favoring a ovarian malignancy being a postmenopausal, and the presentation of an abdominal distension and abdominal pain, that's that it's for that of a ovarian malignancy. Then for a colonic malignancy, we do not have a symptoms of the melena or a bleeding PR or a or altered bowel habit. So that is a negative point, considering that of the colonic malignancy. And also regarding the gastric malignancy, she has some she complains of decreased food intake, but still there is no vomiting or hematemesis or okay, that also is against that of a gastric malignancy, but there is a chance that all the 3 DDs can be there.
Is weight loss a significant risk in any of this?
No, there is no weight loss, or there is no weight loss, sir.
If there was weight loss, what would you consider?
If there was weight loss, I would have given more weightage to that of the gastric malignancies, sir, causing a decreased.
So that is the answer. That's the answer. So if a patient comes to you, you would see malignancy as your primary diagnosis here at this point, right? You are going to consider ovarian malignancy as your primary.
Yes, sir. Yes, sir. I'm going to consider ovarian as my primary, sir.
All right. All right.
Okay.
So carry on. Go ahead with your.
Sir, the voice is a little less, sir.
I'm on 2 devices.
Yeah.
Okay, sir. Shall I proceed, sir? Okay.
Yeah, sure. Proceed.
Okay, sir. Sir, coming to the general examination of the patient, after examining the patient consent and in a well-examined route, she was examined, and she has a performance status 1 Her weight is 60 kg, height is 150 centimeter with BSA 1.6 meter square and BMA of 26.6 kilogram per meter square. Vitals were within normal limits. There is no pallor, icterus, cyanosis, clubbing, pedal edema. There is no generalized lymphadenopathy or the supraclavicular nodes or any other inguinal nodes. Breast and axilla were also normal. Per abdomen examination, after obtaining consent and exposing from the nipple to the mid-thigh, the patient is examined in the supine position. And on inspection, the abdomen appears distended, flanks full, umbilicus was central, the skin appears normal. There is no visible scars, sinuses, or dilated veins, no visible pulsations or peristalsis, and all quadrants move equally with respiration. External genitalia and hernia sites were normal. And on palpation, there is no local rise of temperature. The abdomen appears to be soft. There is no generalized tenderness, godding, or rigidity. Girth is 90 centimeter level of umbilicus. There is a mass felt in the abdomen. It could not be appreciated fully. It is firm in consistency, non-tender. Borders could not be made out. There is a restricted mobility, upper end reaching up to the umbilicus, and the lower extent could not be palpated. There is no cough impulse at the hernia site. And on percussion, there was a dull note on the over the lump, and also there was shifting dullness plus. And on auscultation, normal bowel sounds were heard. And the genital examination, external genitalia is healthy. On perspective examination as well as PV examination, it appears healthy. And on bimanual palpation, there was a mass felt in the adnexa, and bilateral fornixes were full. Per rectal examination was rectal mucosa free, no nodularity, sphincter tones was normal, and systemic examination were within normal limits. So to summarize, this is a 61-year-old para to live to post-menopausal lady with history of diabetes, hypertension, dyslipidemia, present with complaints of abdominal distension and discomfort of 2 weeks duration. On examination, there was a mass felt in the abdomen, which is firm in consistency, non-tender. Borders could not be made out. Sir.
Abdul, continue. Abdul.
Restricted mobility, upper end reaching up to umbilicus, and lower extent could not be made out. And on PV examination, bimanual palpation, mass felt in adnexa and bilateral fornixes were full.
Okay, Dr. Abdul, after the clinical examination, what will be your differential diagnosis? Will there be any change in the differential diagnosis, or will it be the same?
The first differential still will be the carcinoma of ovaries, sir. The second differential will be more of a Krukenberg tumor with maybe a GA primary. That will be, and the third rare possibility is the colonic malignancy, sir. So that.
Okay.
You told.
Hello, sir.
Yeah. Hello. Am I audible?
Yes, sir.
Yeah. So you told after the history that the differential diagnosis can be GI malignancy with Krukenberg. So bilateral Krukenberg. So how you are able to tell that without examination that it can be a bilateral GA stomach or gastric malignancy with bilateral Krukenberg with a diffuse abdominal distension? I think you mixed it after the examination. So you can make such a diagnosis only after examination, I think.
Okay.
Because with the history, you can only tell that it can be malignant ascites, it can be GA malignancy with malignant ascites, or but the bilateral Krukenberg, I feel that you shouldn't add in the history. The differential diagnosis after taking history, because we have not examined her. So being a Krukenberg, we cannot tell. You told in the history that it's a diffuse abdominal swelling, not lower abdominal.
No, sir, it's a diffuse abdominal.
So if a diffuse abdominal swelling, I think bilateral Krukenberg shouldn't come in your differential diagnosis after history taking. It can come after, definitely after the clinical examination, you can make it. But in the first instance, if you have told like that, you might be in trouble because you cannot make out bilateral Krukenberg after history. So definitely, your first option is malignant ovarian malignancy.
Yes, sir.
Okay, malignant ovarian. So other than that, second option will be
Second option,
gastric
I think
malignancy.
gastric malignancy, most probably, sir, with a Krukenberg will be my second differential diagnosis.
Okay. Okay. Anything else, Mr.
The third can be it can be a colonic malignancy will be the third differential diagnosis, sir. When the fourth can be, there can be a real possibility of a lymphoma as well, sir. Diffuse involvement.
Okay. With adnexal mass.
Sir, not with an adnexal mass. With the,
You told that there is.
Sir, it is an adnexal mass. I told less. It is less likely. No, sir. The main two DDs, sir. One is CA ovary and second is Krukenberg tumor. That will be the two DDs.
Okay. Why are you not telling that it cannot be lymphoma?
We cannot be sure about that, sir. There can be a chance that it can be lymphoma as well.
Okay.
Yeah, the primary reason why you won't call it a lymphoma is something more than that. You said that in the history that most of the disease seems to be sitting in the pelvis.
Yes, sir.
And there is much in the upper abdomen. What
Yes,
you have is a diffuse swelling, which you feel is because of dullness, that is shifting dullness is present. So you think
Yes,
it is
sir.
ascites. So
Yes,
it is
sir.
more likely that it is something to do with genitourinary than
Yeah.
trauma, right? You also have no
Yes.
B symptoms. There is no fever, no weight loss.
No.
No
Other
B cells.
lymphadenopathy as well.
No
other
B cells.
lymphadenopathy.
No peripheral lymphadenopathy, generalized lymphadenopathy. It is unlikely to present with a abdominal lymph nodes alone, sir, without generalized lymphadenopathy.
That's correct. So that's more common sense answer. Since there are no other clinical symptoms, which points towards lymphoma. So that's why you're thinking your ovarian cancer diagnosis is much higher.
Okay, sir.
You know something about ovarian malignancies? If you're asked to tell you're in Trivandrum, so what is the average number of patients you get there, or you have read something about ovarian statistics? Do you know anything about Trivandrum and ovarian statistics?
Sir, actually, the statistics was like a 2012 to 2014. There was a cancer registry from RCC, and as per that, the lifetime risk of ovarian malignancy is around 1 in 7. But generally speaking, the ovarian malignancy lifetime risk is around 1 in 75, sir.
No, I asked specifically for Trivandrum. Some data.
Sir, as per the Trivandrum RCC cancer registry, sir. That's the data that is.
There is a national cancer registry, man, which talks about Trivandrum as one of the cancers.
Oh. Okay.
So what is it per lakh population that you get of ovarian malignancy? Something that you know, because when you come from a particular city, either you're from that place or Chennai or Kollam, they will obviously ask you that. You need to know what the average crude incidence rate or crude death rate is. Okay. So in a patient, you said there is no family history of malignancy, right?
No, sir.
So if in case there was family history of malignancy, what would you be considered? What would you be considering?
If there is family history of a malignancy, then the first differential will be a carcinoma ovary, sir. Especially if the patient's family is having a ovarian malignancy or a breast malignancy, especially in a first degree related, then we'll be thinking more of a.
Yeah, you're talking about BRCA associated.
BRCA association, sir.
So if you're given a choice between a patient who is not BRCA associated versus somebody who is BRCA associated, what is the percentage of patients with ovarian malignancy?
Sir, in BRCA one, In the BRCA1, the association of ovarian malignancy is 60%, and in BRCA2, the association is 20%, sir.
What about general population? What about general population?
General population risk of ovarian malignancy, it is around 1%, sir. 1.3%.
Okay. So that also matters, because when you say family history, it's a very vague statement when you say there is no family history. You need to tell me what the family history is all about, and which are the patients, which are the malignancies that you're talking about in terms of the diagnosis that you're thinking of. If in case you're talking about ovarian malignancy, and what are the other related malignancies that you would talk about in the family, and in which members did you specifically ask for? When you say it's not there, it gives the option to the examiner to ask up to what degree did you ask for a pedigree chart, did you draw this, draw that. Those are questions that you invite when you say a blank statement as no family history. It's best to just address it right there and finish it off, saying there's no family history of breast cancer or ovarian malignancies in this family, or whatever else that you want to talk about, whichever other genes you want to talk about. Okay?
Okay, sir.
All right. So, Nathan?
Yeah, nothing else, sir. I think we can proceed.
Okay.
Yeah, with this, what will you proceed? How are you going to proceed with this?
Sir, we probably think that this is a ovarian malignancy. So we will have to first do an ultrasound of the abdomen to see what we are dealing with, whether we are dealing with a malignancy per se. Then second, we'll have to also see the tumor marker, the CA125, whether it is correlating or not. And also we have to look for other markers like it can also be a germ cell tumor. So the AFP beta HCG LDH should also be done. And also there can be a rare possibility of a lymphoma. So the LDH and the peripheral smear also has to be done. So these will be these and all the routine blood investigations, including the CBC, complete blood count, the renal function, liver function test, the chest X-rays should also be done as the baseline workup, sir. And further imaging should be based on that, sir.
Okay, so you did a CT scan, and you also did all the tumor markers. You mentioned doing alpha-fetoprotein beta HCG in a 61-year-old. What sort of malignant tumor, germ cell tumor were you thinking of? What is a common germ cell tumor that you see in a 60-year-old? I would have understood if you would have said it for a 30 or 35 or a 40-year-old.
Yes, sir. It would have more seen in the younger age group, sir. Germ cell tumors.
So it's quite interesting to have a 60-year-old coming to you with any of the germ cell tumors. It's quite uncommon.
Okay.
Right? It's more like an epithelial ovarian malignancy. Could this be a sex cord stroma tumor? You said germ cell tumor. You also said probably one of the epithelial malignancies. Can you classify the subtypes? Would you be able to tell us?
Sir, basically, the ovarian malignancies are divided into three subtypes. One is the epithelial ovarian malignancy. Second is the sex cord stromal tumors. And the third one is the malignant germ cell tumors, sir. That's
correct. So could this be a sex cord stromal tumor? What are the sex cord stromal tumors that you know of?
The thecomas, and the yolks, leading cell tumor. Sertolin. Oh, sorry, sir. Sertolin leading cell tumors.
That's correct.
Yolk sac
tumor.
Yolk sac tumor.
Yolk sac tumor is not germ cell.
No, that's a germ cell tumor, sir. Okay, sir.
That's not a sex cord tumor.
Sex.
This is the other one. More common that we see much more common, other than Sertoli and Thecomas that you said? What are the other common ones? The more common one that we see? There's a juvenile kind, there's an adult kind. Yes, somebody has put it up on the chat also.
Yeah.
Okay, sir. Granulosa, sir.
Okay. On chat, it's a nice help to Abul.
Okay, sir.
Granulosa says, is there any specific marker that you could probably look for if you're given a choice? What is the marker for granulosa cell tube?
Granulosa.
Okay. I didn't know, sir. Okay. Yes, sir.
That's correct. Among the epithelial ovarian cancer, would you be able to classify? Would you be able to classify epithelial ovarian cancers?
Sir, hello.
Yeah. Can you classify the epithelial ovarian cancer? You said germ cell, sex cord, tumor, stromal cell. The epithelial ovarian cancers are one bulk, or are they again different kinds?
Yes, sir. They are also classified into the serous tumors, which can also be the high-grade serous or a low-grade serous tumors. The serous tumors accounts for around 90% of the epithelial tumors. Then there can be the mucinous tumors, then the clear cell tumors, then the endometrioid, then the undifferentiated types, then Brenner tumor.
Okay. So, do the serous and the other types that you mentioned, they all belong to the same category, or do they behave differently?
Sir, they behave differently, sir. The CA125 mark is the markers will be elevated mostly in the serous tumors, but in the most of the other subtypes, the markers won't be elevated, and also the presentations, the high-grade serous will be having a more aggressive presentations. The others, like a short duration of presentation with these florid symptoms. The others might be a little more less aggressive presentations. Then also regarding the mucinous tumors can be presenting with a peritoneal kind of presentation.
Only high-grade serous carcinoma is high-grade. Any other epithelial carcinomas which are high-grade?
Sir, in the endometrioid also there is a high-grade and a low-grade type, sir.
Okay. So what do you think? Means by the history and examination, do you think it's an epithelial ovarian cancer or a granulosa cell tumor?
Epithelial ovarian cancer, sir.
So you have done an ultrasound abdomen. So what are the features of a malignant ovarian tumor in ultrasound abdomen?
Sir, it will be mostly of a complex tumor with both solid and cystic components. And then there can also be associated ascites. Then
the Bluetooth device is connected successfully.
Then the regarding the margins will be irregular. Then the
of what will be irregular?
Margins.
Margins of what?
Margins of the adnexal lesions, sir.
That is mostly irregular in most of the cases. I mean, it's a
okay, sir.
large part. Sometimes you're not able to make out somebody with lots of ascites. Do you have some different irregular margins with any particular type of tumor? Don't think so.
Okay, sir.
No, carry on.
Sorry, mostly it will be a complex cyst, sir, with both solid and cystic component. That will be the key feature. And
if you're saying it's carcinoma, I want you to tell me what are the other tumor markers you will send for mucinous carcinoma.
Yes.
You've got a CA125 of 500. Any other tumor markers you want to send for mucinous carcinoma?
CA will also be with mucinous carcinoma.
Okay. Mention CA and anything else? Somebody's answering in the chat, so we can probably.
Yeah.
Okay, sir. CA 19 and okay.
I think it's better not to answer in the chat box.
There's no way of interesting that box, so it's okay.
Yeah, no problem.
CA 99 is also something that you can probably look for. Mucinous carcinoma generally that would be high. CA 125 is also known as what?
Sir, didn't hear, sir.
CA 125 is also known as what?
CA 125. Cancer and antigen 125.
Yeah, other than that? Okay. That's all right. So you did a cross-sectional study, and yeah, somebody has answered that.
MUC16 gene, sir. That's a gene. Okay.
Yeah. So you've done a study, and on the cross-sectional study, you have somebody who's got a large adnexal mass, about 14 to 12 centimeters. The ovaries are not separately made out; it is arising from the right ovary. Are you able to follow what I'm saying?
Didn't hear, sir.
All right. On your cross-sectional imaging, you found a 14 into 12 centimeter large lesion arising from the right adnexa. The left side has nothing. The right side ovary cannot be separately made out. There is gross ascites, and there are multiple small deposits which you can make out in the pelvic area, on the pelvic peritoneum. All right. CA125 has turned out to be about 600. How do you take it forward? What is the next step that you will do?
So, sir, there is a mass in the abdomen with ascites and the peritoneal deposits, right, sir?
Yeah, what I said was single-sided right side adnexal mass 14 centimeters.
Okay,
there are
sir.
some pelvic peritoneal deposits you can see, and there is moderate to gross ascites. What is your next?
Sir, regarding that, we have to confirm it by the ultrasound and the CT scan, and further
what we
have to.
CT scan already done.
Okay, sir.
Sir.
Okay, sir. So we can proceed with a biopsy of the mass lesion to prove that it is a ovarian malignancy, sir.
How would you do a biopsy? FNAC is sufficient?
No, sir. We have to go for a biopsy of the lesion.
Okay.
We can do for a CT guided biopsy or an ultrasound guided biopsy of the lesion, sir.
Okay.
All right. You did a biopsy, and it has come as clear cell carcinoma.
Okay, sir.
Clear cell carcinoma of the ovary. What do you do next?
Clear cell carcinoma, sir. So basically, clear cell carcinomas are regarding the treatment option, sir. Is it regarding the treatment option?
No, what is the next thing that you do? You've got this biopsy. You wanted a biopsy. So we sent this patient to ultrasound guided biopsy, got a biopsy done. The report came back as clear cell carcinoma of the ovary. What is your next plan of action? What do you want to do with this patient?
We have to do an immunohistochemistry.
Okay. What immunohistochemistry are you going to ask?
For ovarian malignancy, the basic immunohistochemistry includes the WT1. We will be looking for WT1 Paxate. That will be the.
Both are positive. Both are positive. WT1 is positive, Paxate is positive. You want anything else?
P53.
Okay, P53.
So
wild type.
that
P53 wild type.
P53 mutation, sir.
Wild type.
P53 is wild type.
Okay, sir. So the P53 wild means it can
Okay, so that is a lesson to learn when you
Okay,
are
sir.
given a diagnosis. When you are given a diagnosis, best is to just continue and carry forward. You don't ask for more trouble. Okay.
Okay, sir.
If you say IHC, then you get circled up in IHC, and there will be so many more answers to give. Best is to just move on, because your aim in giving an exam is to get to a point of starting a discussion on the treatment.
Okay, sir.
All right. So if the examiner is not giving you an option of IHC and he just gives you a straightforward diagnosis, just say, okay, sir, diagnosis made. This is what I will do next. That is
Okay,
what
sir.
your option should be, because you want to jump quick into the treatment aspect. Okay,
Treatment
that is where
aspect.
you are understood. That
Yes,
is
sir.
where
Yes,
you
sir.
Or if you should know very well about IHC. You should be well read about
Otherwise-
IHC. You should
Okay,
score point on IHC.
Okay, sir.
IHC is a very confusing place. Once you go there, then you get correct. You get cornered, and you will get stuck there. Okay.
Okay, sir. Okay.
So that's the reason a lot of us, because we don't really get interested in discussing IHC. We're more
sir.
interested in finding out how you will treat the patient. All right.
Okay.
So let's say we have got a clear cell carcinoma diagnosis. What do you think is the stage clinically?
Sir, clinically it will be at least a stage 3 malignancy, sir. Stage 3 CO ovary.
Stage 3C. Somebody did suggest on the chat box saying you will do a CT scan of the chest.
Thorax, sir. Yes, sir. CT scan of thorax has to be done to rule out any pulmonary, either a pleural effusion or a lung metastasis, sir.
Good.
Do you
Now,
regularly
CT
do it
scan,
for all CO ovaries?
do you do it for CO ovaries regularly?
All CO.
Sir, chest X-ray is enough. But if there is any suspicion, then we can go for a CT chest, sir.
All right. So how often do you do a CT chest in your case, in your patient? How often have you seen a lung metastasis in CO ovary?
Less likely, sir. Less likely, sir.
Very less likely. So it's not an absolute mandatory thing to do a CT chest, because most of your CT abdomen will cover up to the nipple area. So that should be generally enough. Unless you see abnormal basal metastatic lesions, you really don't need to do a CT chest. So you've got this patient. He's got a stage 3C. Okay.
Okay, sir.
You agree with that?
Sir, it is a pre-disease, but nodal involvement.
You need a nodal involvement for 3C?
Yes, sir.
Okay, tell us what is FIGO stage 1, A, B, 2, 3. Go ahead.
Sir, FIGO stage 1 means that the tumor is 1A means confined to one ovary, and 1B means that the tumor is confined to the both ovaries, and 1C means that there has been a capsule rupture, or the tumor is present on the surface of the ovaries, or there can be an ascites, or the peritoneal cytology is positive. And 2 means that the tumor is present in both ovaries. 2A means that the tumor is present in both ovaries, and 2B means that the tumor, both ovaries and the fallopian tubes. 2B means that the tumor has extended to other pelvic structures. Then 3 means that the there is peritoneal metastasis, and microscopic peritoneal metastasis 3A. 3B means that there is a macroscopic peritoneal metastasis, and 3C means that there is the lymph node involvement, pelvic lymph node involvement 3C1, and para-aortic lymph node involvement 3C2, and then the stage 4 means that it's a disseminated malignancy, sir. With the stage 4 means a pleural effusion, and stage 4 means that the rectal mucosas. There's a extensive diseases with the involvement of the rectum.
Yeah, if there is large peritoneal deposits, 3-4 centimeter size peritoneal deposits, what will be the stage of the disease? According to you? No, please don't write.
Okay, sir. It is 3C.
According to you,
more than 2 centimeters 3C. It is less than 2 centimeters 3B, sir.
Okay. So where does the nodes come? You told para-aortic nodes 3C.
Yes, sir.
So it is 3C. I think it's according to the size of the peritoneal deposits.
Okay, sir. Oh, sir. Okay, sir.
Okay.
So let's say the most common case scenario or the stage that you see in your clinical practice. What is it?
Mostly what we see is a patient present with an ascites, sir. That will be the most common clinical scenario of a presentation.
What stage would that
be? With an ascites and a peritoneal with peritoneal extension. 3C will be the most common presentation, sir.
3B or 3C?
3C's will
most common presentation what you have seen is 3C. Most of them.
Sir, 3B, sir. Maybe less than 2 centimeter peritoneal disease. 3Bs.
Okay, what Mithun and we see mostly is 3C with large peritoneal deposits. I think all the good ones you keep and we send all the bad ones to us here.
No, sir.
Is that true?
No, sir. 3Bs and 3Cs, sir. 3Cs.
The moment our gynecologists see it, they make us come the other way. So it is mostly 3C that we see, but then there might be practice differences. So you're not absolutely wrong. But most of us do see stage 3B bar stage 3C as our primary. So remember the discussion that you would have in all the exams. The examiner would always want you to a stage 3C bar or stage 3B situation, because 1 and 2 there is very little to discuss. Stage 4 again, it is a different story. So anyway, if you cross the stage 3, there will be a discussion on stage 4 and recurrent and metastatic and all that stuff. Okay, so the discussion would start at stage 3B, not stage 1 and 2. Very unlikely that will happen. Okay. So you have a stage 3C situation. What do you want to do next?
Sir, we'll have to start the patient on systemic therapy. That will be the first option, because most of the patients with a stage 3 ovarian malignancy will be we cannot achieve a complete cytoreduction upfront. So better we'll be starting with a.
There are no gynec oncologists in this session right now, so I think you will not get beaten up. But if there are good gynec oncologists in this group listening to this, Abul is going to be massacred.
Sir, even if we are able to go for upfront resection, there can be more surgical complications associated, post-op complications as well, sir.
With your gynec oncologist, you've not asked him whether he is able to operate. I think they are able to operate. What is the difference between doing PCS or IDS? Is there a survival difference?
No, sir. No, there is no difference.
There's no survival difference. Patients don't do better if they are doing PCS or IDS, right?
Yes, sir. Either can be done, sir.
either can be done. So why not send this patient for a PCS? Because
Okay,
our discussion, when I told you, we said there is a large pelvic mass, there is ascites, and there are pelvic peritoneal deposits. Now, since you asked, it's more than 2 centimeters. So, why is it not possible to be taken up front for PCS? How would you say at least do a laparotomy and ensure that the surgeon
sir,
is not...
there is a high chance that the residual disease will be left behind if we go for upfront surgical resection in this case, sir.
Not really. Not really. Okay, so tell us what are the reasons why a surgery is not feasible in a 3C? Yeah, all 3Cs are not inoperable or not difficult. There are surgeries that can be done even for
Yes, sir.
3C.
Yes, sir.
So it's not that all patients of 3C will automatically just go for neoadjuvant chemotherapy. That is
Yes, sir.
something
Yes,
that we all do as a part of convenience, but
Okay,
that's
sir.
not true.
Okay.
Okay. So where did the PCS and IDC idea come from? If you go to the US, work there, probably every patient is going to come to you from the surgeon after the surgery is done.
Okay, sir.
Right?
Okay.
So PCS is an option. How do you say PCS is not an option?
Hello, sir. Didn't get the questions.
Why did you say PCS is not an option?
Because
Sir,
you immediately gave...
No, sir. Interval site reduction surgery is also an option, sir.
No, that is an option. If you primary chemo, then interval site reduction is the only option. My question is, why are you not sending this patient for a primary surgery?
Yes, sir. We can. The decision has to be taken. As sir said, the decision has to be taken by the gynecologist, sir. Yes, sir.
Okay. So where do you meet your gynecologist?
Yes, sir. Whether to see if the patient can be taken up for an upfront surgery, if the complete site.
It's a good habit to just mention that you will bring it up to the MDT and have your gynecologist look at this patient and
sir.
tell us whether a possibility is there. So what is the criteria for unresectability? When do you think the oncologist is going to say, sorry, I'm not going to operate on this patient. This is not a resectable condition.
Okay, sir. Sir, when there is involvement of the bowel, the intestinal involvement, then with the stage 4 disease with a distant metastasis. Hello, sir.
Yeah, we are listening. We are listening. Waiting for you to.
Okay, sir. Then the route of mesentery involvement. So that will be the main.
Patient is having pleural effusion.
Sir, pleural effusion and pulmonary metastasis are also unresectable criteria, sir. Brings it to stage.
There is a few liver deposits. Would you operate?
Okay,
would you not operate?
Upfront, yes, sir. If the surgeon feels that it can be resected, then we can go for that, sir.
Okay, that's a diplomatic answer. My question was, if there is a liver deposit, would you operate or not operate? What is your take?
Sir, paragammal means that it's more of a systemic disease. So
then
there's
does it become stage 3 or stage 4? If it's a parenchymal disease, does it become stage 3 or stage 4?
Stage 4 disease, sir.
So if it is generally present, then it is always on the surface. Ovarian malignancy, when you say liver deposits, you always mean that it is on the surface. It is not in the parenchyma. Very rarely that you will get patient in the parenchyma. So liver surface deposits are not a contraindication for surgery.
Surgical resection.
If the surgeon says, yes, I want to see and operate, would you allow them to do that?
If it is a surface deposit, then we can try that, sir. We can resect the liver lesions.
So you have sent the patient for the surgeon to have a look. What would you ask him to do? Would you ask him to just operate and give you a suboptimal resection, or would you ask him to do something else? What does your surgeon do there?
We have to go for a complete cytoreduction surgery has to be done, sir. An R0 resection has to be given, sir.
Right. So if you have to compare the MRI or a CT of the abdomen versus a laparoscopy, which one has a better sensitivity and specificity in terms of telling you which is going to give you a complete cytoreduction?
The laparoscopy is having a better sensitivity and specificity compared to that of MRI, sir.
How much would that be?
Laparoscopy can come up more than 90%, sir, sensitivity and specificity.
Yeah. So, Abdul, if the biopsy came out to be mucinous carcinoma,
okay, sir.
What will be your way of going ahead? It's not clear cell carcinoma; it's mucinous carcinoma.
Sir. Okay, sir.
So, what will be your scenario? In such a patient is having malignant ascites with adnexal mass. Biopsy turned out to be mucinous carcinoma. CA125 is around 100 and CA is around 30, 40.
Okay, sir. Sir, we'll be proceeding with a neoadjuvant. It is better to proceed with a neoadjuvant. Sorry, it is a mucinous carcinoma. So then we'll have to look for the scopies as well, sir, to look if it is a GA origin.
Okay.
Then, yes, sir. And because the appendix can also present with a pseudomyxoma pericroni kind of presentations, mucinous presentations.
So mucinous carcinoma, you will have to do upper GI endoscopy and colonoscopy.
Colonoscopy,
is it right?
yes, sir. Yes,
all
sir.
mucinous carcinoma. CT scan has been done. There is only adnexal lesion with ascites. Biopsy mucinous carcinoma with some pelvic peritoneal deposits. Unilateral, not bilateral.
Yes,
you will go ahead with endoscopy or any difference in bilateral, unilateral?
Sir, if it is unilateral, it can be most probably with an ovarian origin.
Okay.
Sir, not sure. No, I think if it is a unilateral, it can most probably be an ovarian origin, sir. Bilateral, most probably might be an GA origin, sir.
Okay. Yeah, bilateral definitely GI origin, more chances. But unilateral also, mucinous carcinoma, PA increased, there can be a chance. So better to go ahead with endoscopy.
Better to do for a scopies of the upper and the lower GS, lower colonoscopies.
Okay. That's one point you should always think about. Mucinous carcinoma, mucinous carcinoma biopsy report. Should always think about endoscopy and colonoscopy if required.
Yes,
okay. Sir. So if it's a mucinous carcinoma ovary, in such a scenario, what will be your option? Will you still go ahead with the neoadjuvant chemo or more chances of surgery?
No, sir. I'll proceed with the neoadjuvant chemotherapy, sir.
Okay.
With a 4-4, and the regimen most probably will be a 4-4 regimen, sir, for a mucinous carcinoma.
Okay. So you'll be planning for Colfax regimen followed with surgery.
Followed by interval cytofraction surgery, sir.
Okay. What do you think? How is the patient? Yes, sir.
Let's assume that you did a biopsy and there's a lot of mucin that you found. Okay, but you did not find any invasive component. Did you understand what I said?
Yes, sir.
What would you do? Would you give neoadjuvant chemotherapy? And how common is it that we give mucinous chemotherapy? How do we plan our neoadjuvant?
Sir, if the invasive component is not there, then
what is DPAM?
sir,
what is DPAM? DPAM.
no, sir. Sure. Sir, I'm not sure, sir.
Okay. So you have decided on the primary cytoreductive surgery, and surgeon says he can operate. He does the surgery. He's got a suboptimal cytoreduction done. Okay.
Okay, sir.
After the suboptimal cytoreduction, this patient comes to you. What would be your treatment choice now?
Sir, if the patient is a rewide excision to fully achieve a carcinoma resection will be the best option for the patient.
Surgeon has worked hard for 4 hours, 5 hours, and he managed to get a suboptimal. He's not going to go inside again. The relatives will kill him. So
Okay.
obviously, he's coming to you. What do you do next?
Then
Send him back for more.
Then the option will be to go for adjuvant chemotherapy, sir.
Okay. So what is the adjuvant chemotherapy you're going to offer?
Sir, Colfax will be the chemotherapy regimen that we'll be going to opt for mucinous carcinoma.
Talking about a
Yes,
serous
sir.
high grade.
Serous.
Yes, or a serous high. What do you do?
No, you didn't hear, sir. Once more, please.
Serous carcinoma. Histology serous carcinoma.
Serous carcinoma. If the histology is a serous carcinoma, then and if the surgeon feels that it is it's a incomplete cytoreduction, right, sir?
Yes.
Yes, it's an incomplete cytoreduction.
We have to go for a paclitaxel carboplatin based chemotherapy regimen, and since the patient is having ascites, we can also add bevacizumab to the regimen, sir.
Okay. So you have any data to support your treatment protocol of giving bevacizumab adjuvant in a patient with suboptimal resection?
Sir, as per the ICON 7.
ICON 7 population was what?
Sir, that's actually pre-op bevacizumab.
Yeah. So this was not post-op. This is an adjuvant setting.
Yes, sir.
Is it 6 cycles of paclicarbo? How many cycles of paclicarbo would you do?
Sir, 6 cycles of
paclitaxel and carboplatin.
Paclitaxel carboplatin, sir.
All right. So if this patient had come to you upfront, the surgeon refuses to operate in the first hand, saying it is not operable. What would you do then?
Sir, the regimen would have been a paclitaxel carboplatin plus a bevacizumab based regimen, sir.
So paclitaxel, carboplatin, and bevacizumab is the standard of care for all patients who come to you with 3B or 3C. Is that correct? Is that right? I'm assuming.
That will be the best option, sir.
Why is that the best option?
Sir, because the in the evidences we have tried the 3-drug regimens, but as per the ICON trials, ICON 5 trials, but that did not show any benefit. And also the dose-less paclitaxel was also tried, but that has only shown some benefit only in the Japanese population. So considering the tolerance of the chemotherapy and tolerance, so we'll be in more for a paclitaxel carboplatin 3-weekly based regimen, sir.
No, you told about paclitaxel, carboplatin, bevacizumab. So what is the extra advantage of adding? What is the advantage of adding bevacizumab to the pacli-carbo regimen?
Sir, the extra advantage is that in the bevacizumab studies, the ICON 7 and the GOG 218, the advantage is that the bevacizumab can be given in the maintenance as well, sir, for a 1-year period.
So you're starting bevacizumab so that you can give bevacizumab in maintenance.
Yes, sir.
So what is the advantage of giving bevacizumab?
Didn't seem to make a difference, did it?
There was a survival benefit, sir. PFS and OS benefit was there, sir, with the addition of bevacizumab. The survival benefit of a median OS of around 10 months benefit compared to patients without bevacizumab, sir. 7 as per the ICON 7 trials.
Okay.
So the patient is, let's assume a patient who cannot take bevacizumab. Give me 2 contraindications for giving bevacizumab.
Sir, one is the patient is having hypertension. Second is there is a chance of GA perforation.
Malayalis have hypertension.
Excuse me, sir.
All Malayalis have hypertension.
Sir, the BP should BP more than 160 by 100, sir.
That can be controlled, right?
Yes, sir, it can be controlled. That's not an absolute contraindication. It can be controlled.
What are the absolute contraindications?
Absolute contraindication is the GA perforation is the absolute contraindication, and the bleeding risk is the absolute contraindication, sir.
Okay. So this patient cannot afford to have bevacizumab for medical reasons, not financial. Okay.
Okay, sir.
So what would you do there?
Sir, then the regimen will be that of a paclitaxel carboplatin based regimen only, sir.
All right. Let's say this lady was 75 years old, a little frail. Okay. And the comorbidities are there, significant comorbidities are there. Comes with the same situation. Would you give pacli-carbo?
No, sir. The single agent. No, sir. Single agent chemotherapy. Single agent chemotherapy.
Or any other modification that you can make in pacli-carbo?
Exactly.
Any other regimens?
Abul, we lost you.
Yes, sir. I'm here, sir.
Okay.
So is there, you said pacli-carbo you will not use, instead of 3-weekly you will give single agent drug. So if you give single agent drug, what is the margin of loss that you are creating for the patient? Do you think single agent is as good as pacli plus carbo?
Versus a pacli-carbo, single agents.
Answer to that question, you should not give a single agent, because a single agent is definitely inferior to using
yes, sir. Inferior. Yes, sir.
And if the patient is frail, you can use a weekly carbo plus paclitaxel at a smaller dose. That is still found to be better off than giving a single agent carboplatin. Okay.
Focus.
So unless the patient is PS4 and about to die and you still want to give something, maybe you can. But most of the time, you should be able to give a weekly pacli and carbo. Now let's say we did pacli and carbo. when do you want to reassess and when do you want to send this patient for surgery?
Sir, after 3 cycles of chemotherapy.
Why 3 cycles?
No, sorry, is that a frail patient, sir?
No, it's a normal patient. You are 60-year-old.
No,
Your patient.
After three cycles of chemotherapy, we'll reassess the patient and we'll send for the interval site reduction, sir.
Why do you want to send after 3 cycles? Is there a logic or it is just a number game? Why do you want to send after 3 cycles? Is there any data to support after 3 cycles? I want to give 4. Midhan sir wants to give 5. There are people who will give 6 and send the patient for surgery. What do we lose?
We usually send it for after 3
No, the answer should not be we send it.
Yes, sir.
What is the logic of sending after 3 cycles?
Sir, one is the tumor shrinkage for a better surgical outcome, for a better R0 resection.
So then it's better to give after 6 cycles, no?
Yes, sir, that can also be achieved.
More reduction.
Yeah, you give 6 cycles, it will become much smaller. Maybe it will disappear.
Sir,
okay.
From the EORTC trial.
Yeah, what trials? You know the trials which have been done for IDS? What are the important trials that we have for interval debulking surgery?
Sir,
and what is the kind of therapy they have used?
EORTC trial, sir.
Okay, EORTC trial. Any other trial? Okay, important because this is the most important
trial.
Vortex trial is for endometrium.
Okay.
There's something about a singing trial. What is that trial?
Sir, didn't hear, sir. Something
Singing trial. Okay, somebody put it on the chat.
Chorus trial.
Chorus. What else? Somebody else. Something that bites you.
Scorpion trial. Okay.
Scorpion trial. Any other trial you know? Things that only Japanese can do. Obviously, has to be trial. They don't give all fancy names. They give all this JCOG trial. Okay. So there are 4 important clinical trials that are there for IDS versus upfront surgery. Okay.
Okay,
so
sir.
even the chemotherapy idea of how many cycles you should give comes from there. That is the largest subgroup that we have. Okay. Most of them gave how many cycles? Your answer was correct. 3 cycles.
Three cycles.
Whether it was the other 2 trials, Chorus and the whatever that EORTC trial was, they all gave 3 cycles followed by IDS.
Okay, sir.
How much did Jacob give? Jacob gave 4 cycles. Before chemo and 4 cycles after, before surgery and 4 cycles after surgery. So you have 3 cycles before and 3 cycles after comes from these 4 important clinical trials, which has looked at IDS versus PC. Okay. And the logic there for not giving more than 3 or 4 cycles or recommendation to give surgery after 4 cycles is that the longer you keep the chances of more resistant clones arise, which basically means you will end up having a situation where you have very few cycles left over to give. So as soon as it is fit enough for a surgery, you should take the patient for a surgery. Not wait for 5 and 6 cycles complete because the surgeon doesn't have the time. All right?
Okay, sir.
All right. So you have done the surgery, and after the surgery is done, the report has come back as residual disease. It is still stage 3C. But the ascites has disappeared. You have not given the bevacizumab.
How long is KBC? When is starting? Oh.
Sir, there is some. I can hear, sir.
Yeah, please, others, can you mute your mic? Yeah.
So you have done a surgery finally after 3 cycles of chemo. It has
Okay,
come
sir.
back as residual disease, and
Okay, sir.
there is still 3C left. Okay, ascites is significantly reduced, but there are gross peritoneal deposits. So
Okay.
where do you go now? What do you want to do?
Sir, the intra-op itself, we'll have to go for a HIPEC for the patient during the surgical, or after the surgery is completed, right, sir? Is that so?
Yeah, you could probably suggest, yes, you would want to do HIPEC. What is the indications for HIPEC?
Sir, one is the patient who has a uh, gross peritoneal disease with ascites, then for whom you can achieve an R0 resection.
There's nothing called R0 resection in ovary, is there?
Complete cytoreduction.
What do you understand by complete cytoreduction?
The
definition of
the residual disease should be as little as possible, sir. Means previously the cutoff used to be around 1 to 2 centimeter, but now we say that all the microscopic disease, most of them should be means like it should even be less than 1 centimeter residual disease left behind.
Okay.
So Abul, do you think? Yeah, Abul, just a second. You told that HIPEC. So most of our patients come in stage 3B and stage 3C. So according to you, most of our 90% of our patients should get HIPEC. You're telling like that.
No, sir. If the surgeon could achieve a complete cytoreduction surgery only, then the role of HIPEC is there.
Yeah, after 3 cycles of neoadjuvant chemo, most of the patients will be able to get a complete cytoreductive surgery. So you're
Okay,
telling most of the patients will be in stage 3B and stage 3C.
Okay, sir.
Majority, many patients. So all these patients should get HIPEC.
No, sir. So the HIPEC is mainly associated with for preventing the recurrence-free survival.
So
basically in the
which all conditions you prefer HIPEC?
Stage 4 with the gross ascites, sir.
Stage 4.
Yes. Not stage 4 with a stage 3 with an ascites, sorry, gross ascites.
Okay. Stage 3 with gross ascites.
And extensive peritoneal disease, sir, because the systemic chemotherapy, there will be less chance for systemic chemotherapy.
Peritoneal tumor? How much how do you measure it? How does the surgeon measure it? Is there a way to do that?
Sir, I'm not sure of that.
So there's something called peritoneal carcinomatosis index. Have you heard of it?
Yes, sir.
What is peritoneal carcinomatosis index?
No, I'm not very sure about that.
So you haven't met your gynec oncologist yet. Please go meet him. He'll tell you what peritoneal carcinomatosis index.
Okay.
Okay. Anybody in the group who will know how much is the PCI that you operate for and what is the maximum PCI? Leave it in the chat. Okay, now you've done this and let's say HIPEC is what you want to. Yeah, somebody has said the answer, 39 max. And less than 15 also somebody has mentioned. Good. So when you do a PCI, patient is PCI of 12 or 13, want to do a HIPEC. How will you go ahead with a HIPEC? If you
So basically, during the after the complete cytoreduction, the patient will be connected to the hyper machine, and the temperature will be around 41.5 degrees Celsius, and the chemotherapy, usually the chemotherapy given is cisplatin at a dose of 100 milligram per meter square, that is being circulated for an hour, and usually we proceed with a closed hyper procedure, sir. And the chemos will be then washed out. That is how the hyper.
You're giving a 100 milligram dose. What is the biggest complication that you fear?
Sir, one is the systemic absorption of the chemotherapy.
Adverse effects of hyper after surgery.
Sir, one is the systemic absorption of the chemotherapy and the associated renal toxicities and bone marrow suppressions and the infected complications, sir.
How can you prevent it?
Other than that,
Sir, the chemotherapy agent should be circulated only for an 1 hour period, and the chemotherapy agent should be washed out promptly. And also the post chemotherapy, the patient should be followed up for the dyslipidemia, and the renal parameters should be closely followed up, sir.
Any drug that you can give to prevent the toxicity?
Sodium I didn't know that, sir. Sodium thiazole.
Sodium thiazole.
Okay, sir.
Now this patient has got a hypec. He's come back to you. You give another 3 cycles. Okay? And then what do you do? Another 3 cycles of chemotherapy. Would you want to add bevacizumab now? After hypec, or if the patient did not get hypec, any particular condition where you want to add adjuvant bevacizumab? And if you know any trials?
yes.
Yeah.
Adjuvant bevacizumab is in tumors, patients with residual disease more than 1 centimeter, sir.
Right. So after hypec, is there anything that says you can do?
After hypec, no, sir.
No data. All right. So if there is no hypec, you could probably still consider bev. When would you start? When would you stop?
Sir, bevacizumab should be started only after 4 weeks of the surgical resection for wound healing, and the patient can be kept on the bevacizumab maintenance for a period of 1 year, sir.
All right. Let's say this patient has come to you. There is a strong family history. Would you have any considerations in terms of treatment?
Yes, sir. If the patient is having a strong family history, there can be the mutation testing has to be done, and the BRCA mutation especially has to be done, sir. And if the BRCA mutation turns out to be positive, then the maintenance therapy we can try for the PARP inhibitors as well, sir.
If there is no family history, then you are not going to do.
No, sir. For ovarian malignancy, we are doing, sir. For the
What you're doing?
The HRD testing, sir, homologous recombination defect testing.
Okay. When you do it?
Yeah, I will tell you to do a HRR test. Would you do that, or will you do HRD test?
Sir, HRD means that we can look it at the pathway is defective. HRD means that. So that will be the one that we should be doing, sir.
Okay. What is HRR testing then? Why do you not want to do it?
HRR means that we are looking if the gene is defective or not.
Okay. So when you ask for a BRCA testing on these patients, what are you doing?
Sir, for BRCA, regarding the treatment part, sir?
No, no.
Yeah. What do you do? What do you do for testing? You do HRD, you do just do BRCA1, BRCA2, or you do something else?
We do HRD.
For all your patients. For all your ovarian malignancies, you should do HRD or
HRD and germline BRCA testing and HRD.
Okay. Well, when you say HRD testing, what are we looking for?
Sir, HRD testing.
How do they find out HRD is positive or negative?
Sir, basically the homologous recombination repair pathway, the BRCA gene is involved in the repair pathway, while other genes are also involved in the repair pathway. So basically, a defect in any of the genes can result in a HRD.
HRD testing is basically looking at the outcomes of HRR function loss. So you're looking for chromosomal or DNA scarring. Okay. One of the ways of looking at scarring is to see whether there is a chromosomal absence, areas of chromosomal deletion, or loss of heterozygosity. Those are things that you are looking for when you're doing HRD test. HRR, on the other, is looking for the genes absence or presence. Now, how many HRR genes do you know of? One, we all do BRCA1 and 2. Are there other genes that are involved in this pathway?
Sir, HRR, RAD51C, 51, RAD51D, then the ATM BRIP1 gene, then the MSH2, MSH6. So these are the main HRD genes, sir.
All right. So if the BRCA is negative in this patient, I still want to give PARP inhibitors. You think it is possible?
Niraparib can be tried in both settings, sir.
Right. What trial said niraparib can be tried in patients with no BRCA gene test positive?
Means the BRCA, whether it is a BRCA wild or a BRCA mutant, then niraparib can be tried as per the primer trial, sir.
Okay. Anyway, you've been getting a lot of chat benefit out of this room. So it's okay, but these are good points. I think you should write down and make sure that you have answers for all this. Okay.
Yes,
niraparib is used. Why is it that niraparib is better, but olaparib doesn't seem to work? Next question. Data says so that niraparib can be used. Why? They all are PARP inhibitors. Why one drug works, the other doesn't?
No, sir, I'm not sure.
Excuse me.
Can you use PARP inhibitors with anything else?
Excuse me, sir.
Can you use PARP inhibitors with anything else? Can you combine it with anything else?
Bevacizumab.
Yes.
Sir. With Bev.
Which one?
With bevacizumab, sir.
Which PARP inhibitors usually combined with
olaparib?
In which all conditions?
In CO ovary, sir, as per the Paula 1 trial, sir.
So if it's BRCA positive,
sir, if it is a HRD positive and a BRCA mutant.
You need HRD positive and BRCA mutant, both.
Olaparib can only be used if it is a Sorry,
Olaparib single agent is used in which conditions?
HRD, wild and BRCA mutant.
HRD wild and BRCA mutant.
Would you get
What
that?
is HRD wild?
Sir,
What is HRD wild?
sir, HRD. Sir,
If BRCA is positive, will HRD will be positive or not?
HRD will be positive, sir.
Okay. So what is HRD wild BRCA positive?
No, sir, it is wrong only. It should be HRD should be positive mutant if BRCA is
okay
mutants.
All right, Abul, we have 5 more minutes to wind up.
Okay, sir.
Mithun?
Yeah. So so you have given 3 cycles of adjuvant chemo. After that, what will be your line of management? In HRD positive case, BRCA wild type.
HRD positive, BRCA wild. Sir, niraparib can be.
Niraparib is available in India?
No, sir.
Okay.
Rucaparib also.
Okay.
Then the olaparib plus bevacizumab is also an option.
Okay.
Or single agent bevacizumab is also an option. Maintenance. If the patient was not started on bevacizumab, so it will be PARP inhibitors will be.
Okay, what will happen means the patient has relapsed at 4 months of treatment.
Okay,
4
sir.
months post treatment. So, what will be your next line of management?
So the
4 months the patient again has developed ascites on post 3 cycles of adjuvant paclitaxel, nothing has been given. For 4 months, she again developed ascites.
Okay, sir. So then we'll have to first drain the acidic fluid and we'll look for the cytology and the and
okay.
And then if it is a relapse, the patient is a platinum resistant patient, so the platinum is not going to work in the second line setting, sir.
Okay.
Okay, sir. So the agents can be
Gemcitabine, single agent, or gemcitabine.
Them with
in platinum resistant cases, what will be the best second line?
lipodox. Liposomal doxorubicin.
Okay. And will you add bevacizumab in such a scenario? No.
We can recurrences. We can add bevacizumab plus paclitaxel.
Paclitaxel.
No, with the lipodox. With lipodox.
Okay. So you will be giving lipodox plus bevacizumab.
Yes, sir.
If there is some peritoneal deposits post 3 cycles, will you go ahead with IPEC after in such a scenario?
We can try for the secondary site to reduction
secondary cytoreductive surgery.
if there is residual disease. And if the HIPEC was not given in upfront, then we can try the HIPEC this time, sir.
Okay, so in platinum resistant, you will go ahead with secondary cytoreductive surgery plus HIPEC, or only?
Yes, sir. We can try for. No, sir. We can try for secondary cytoreduction surgery plus HIPEC.
In platinum resistant, not platinum sensitive. This is platinum resistant. There's no difference in platinum sensitive, platinum resistant in this scenario. Is it? I'm asking you. Is it like that, or you will go for secondary cytoreductive surgery in only platinum sensitive cases? Is there anything like that?
No, I'm not sure, sir. No.
Okay. Okay. I think you should look into that.
Okay, sir. Only in platinum sensitive labs. Okay, I'll see.
Okay. Because secondary cytoreductive surgery usually do in platinum sensitive labs.
Sensitive labs is only okay, sir.
Okay. So in such a scenario, will you go ahead with any maintenance treatment? We are given lipodox bevacizumab.
Sir, the bevacizumab can be continued as a maintenance treatment, sir. Or if the patient is a BRCA mutant, then we can try for the PARP inhibitors.
If it's not BRCA mutant or HRD negative, still can we give PARP inhibitors? Yeah.
That's a NIRAP.
Okay. I think, sir, Leslie, sir, it's time to wind up.
Okay.
Yeah. I think this will be the broad line of management. So you should try for these all, means try to refresh on this platinum relapse treatment also you should look into.
Okay. Okay, sir.
Yeah. Okay. Yeah. I think Dr. Munir, are you there?
Yeah. I think that was an extensive session on CO case discussion. So thank you, Dr. Abul and examiners, for this wonderful session. Wesley sir, any comments? We can close the session. I think sir is not here. Okay.
No,
okay. Thank you
so
all.
much for inviting us, me and Dr. Mithun, to come as examiners. It was good, and Abul has done reasonably well. So I hope you are able to brush up a little more of your basics, and that should be good. Thank you.
Thank you, sir.
Yeah, thank you.
Thank you, sir.